Hello, my name is Nicole Steele, and I read about a link between high output heart failure and iron deficiency and wondered if correction of my iron deficiency could prevent development of heart failure. My search did not support this specific question. However, it did highlight iron supplementation as a means of managing symptoms associated with iron deficiency and heart failure and improvement of activity capacity. But which was the better supplement, IV or oral? Iron deficiency is present in approximately half of patients with heart failure. Regardless of etiology, though, iron deficiency is typically first treated with either oral or IV iron. Even with optimal usual therapy, patients often report a decreased ability to enjoy activities that give them purpose secondary to poor symptom control. Iron deficiency correction would provide another treatment option and decrease potential for an emergency visit and possible admission to hospital. 5 randomized controlled trials were found with a variety of search terms, Boolean operators, and from various sources. 4 randomized controlled trials compared IV iron to IV placebo saline. All 4 found improvement of primary activity endpoints in the treatment group with no improvements in the placebo group. And 1 randomized controlled trial compared oral iron to oral placebo. There were no improvements for either group. Overall, a statistically significant improvement in functional capacity for participants receiving IV iron was demonstrated. This intervention will start with baseline lab analysis of serum ferritin and transferrin saturation in order to measure absolute iron levels and serum hepcidin in order to measure systemic stores of iron. The 6-minute walk test and the New York Heart Association classification scale will be used to evaluate measures of activity tolerance. The 6-minute walk test is administered at both my local hospitals. IV iron sucrose will be the chosen iron formulation, as iron sucrose is used for treatment of iron deficiency within my local health authority. I will recommend 1 infusion per week for 3 weeks and then monthly, so long as follow-up lab values do not indicate iron overload. Follow-up lab values should be drawn every 3 weeks, and repeat activity evaluation will be scheduled for 1 month after the initial infusion in order to allow for the maximum time frame needed for response to drug therapy. This intervention is applicable and feasible to my local area, as heart failure exacerbation is the most common reason for hospitalization of people over 65 in my province, and all resources needed for each component of this intervention are accessible. The elements and results of my studies are transferable and generalizable to my current environment, as the local patient population aligns with the inclusion criteria of all 5 trials, and iron sucrose is within my health authority's drug formulary. There are many reasons for which a patient will not consent to an infusion. However, utilization of social cognitive theory may help a patient reshape their paradigm and reinforce the utility of an iron infusion. As well, utilization of Lane's and Pugh's theory of unpleasant symptoms would assist the clinician to better understand the patient's symptom experience and challenge a provider's definition of what it means to be non-participatory. Thank you so much.